you very much, Robert Jan. The next speaker will be Ernest Schilders, and he will tell us about acute groin injuries and if there's any indications for surgery. Ernest is a professor of orthopedic surgery. He's originally from Belgium. Has been working in UK for many years now as a consultant orthopedic surgeon. He is a groin nerd, as the rest of us, very interested in adductors as well, and he's doing a lot of hip arthroscopies. But adductors has been a common discussion area between Ernest and myself for the last 15 years, I think. So we're looking forward to hear all the new stuff.
Hello. Thank you for your kind words, Peter. We're still talking to each other after all those years, and a lot actually. So acute groin injuries. I think the groups that we see as acute groin injuries are adductor longus avulsions, muscular tendinous junction injuries, which is probably the biggest group, and also muscle injuries to the adductor longus and magnus and brevis. Although I think the brevis is a little bit overrated. If we see what the epidemiology is of adductor injuries, we see that it accounts for about 23% of all the adductor injuries in professional football, and 2/3 of those muscle injuries are traumatic with an acute onset. 92% are non-contact injuries, and 10% of the adductor injuries were more severe. So you see those four groups, and obviously the group that we are most interested in is the group where we don't have a return to sport within 28 days. Treatment for acute injuries at the muscular tendinous junction is pretty much established. It's usually a result of an overstretching, bruising on the inside of the thigh, and diagnosis made with an ultrasound scan or MRI scan. It's always treated conservatively, and a return to sport can be expected between 1 and 6 weeks. This is an example of a football player with an adductor magnus injury. On the left side, you can see the immediate post-injury MRI scan, and on the right side, after 4 weeks, and you can see how all the acute symptoms gradually disappear, and at 4 weeks, he was already at a very decent functional level. So these are all indications for conservative management. But let us look a bit more in detail at the avulsions of the fiber cartilage of the adductor longus. And the sports where you can see this, I've listed them here, so I would say predominantly soccer and rugby, but also in different sports, as you can see. Now, it's usually a non-contact injury, and you can see here Robert Groin was the England goalie a few years ago, and when he kicks out the ball, everybody who was watching the game thought he actually missed the ball, but what happens is that when he brings his leg into extension and therefore eccentric loads the adductor, he pulls off his adductor longus, and so by the time that his foot reaches the ball, he has lost control completely, and therefore wasn't able to complete his kick. And this is quite typical how this injury occurs in the majority of the avulsions. Now, is there an etiology of this pathology? Well, we had 19 professional football players between 2012 and 2014 with this injury, and we did find that an astonishing 37% had a pubic cleft injection, recent pubic cleft injection. So I think probably when we deal with patients in this way, we have to manage things a little bit better, as in rehab and deciding on when to return to sport. And we had 3 players with bilateral avulsions, and all of them had more than 2 pubic cleft injections. If we now look at the recreational athletes in that period of time, none of them had pubic cleft injections. The anatomy has been discussed before, but I think it's a good idea to come back to it. I'm not a fan of the plate theory, the fiber cartilage plate theory. as you can see on the arrows, with the arrows is that the adductor longus attached to the symphysis at the front and forms like a conjoined tendon with the inguinal ligament, and above the arrow you can see the pyramidalis muscle. But I think we need to go deep enough, and we have to remove a bit more layers, so don't look at the superficial fascia, but go a little bit deeper. And what you can see is that your central part of your rectus abdominis finishes into a ligament that crosses over the anterior symphysis, and as you can see, it's not connected with the adductor longus at all. If we cut the adductor longus in slices, and we have a sagittal cut to the adductor longus, and you can see how the fiber cartilage actually attaches to the anterior part of the symphysis. So, and we can actually look at that on the right side. You can see that the typical shark fin appearance of the fiber cartilage of the adductor longus. This is a picture that I got from Mike Benjamin, and it actually shows how the enthesis actually how it looks like. You can see the red area on the left of the line is the calcified fiber cartilage, and it interdigitates with the subchondral bone. The clinical symptoms can vary a little bit. So typical for the acute injuries that there is severe pain as a result of an eccentric loading of the adductors. There's always the inability to carry on playing or training. And there's bruising, but the bruising is not always present. And as you can see on the picture on the right below, when you open the fascia, you can see what the true extent is of the damage. Well, your superficial fascia can be intact, and therefore you can even be fooled when you examine the patient. So it's important that you bring the hip, bring the leg a bit more into a neutral position, so you can relax that superlying fascia, superficial fascia a little bit, and try to feel for a gap. Classically, diagnosis is made by ultrasound scan. We use a modification of the protocol that has been published by Phil Robinson in 2004. But now we have to decide, do we go for operative or non-operative management? A study which is quoted a lot is a study from Schlegel, and in the entry you can see that it is stated that the anatomical attachment of the pubis may not be required for high-level function. So I didn't quite understand on what basis that was made. So I decided just to look through the literature on that basis, and what we see is that if you look at all the studies where a full tenotomy was done of the adductor longus, you see that the return to sport is not that great. And so best study is the one from March, but the other studies all have a return to sport between 54 and 68, 69%. Now, not all those athletes in the studies were professional athletes. So, study of Akermark, where you see there's a 20% strength deficit, were only recreational athletes, and in various sports. Atkinson, same thing, recreational athletes. 54 return to sport. Maffoli with a 69% return to sport. And so you can see all those studies, and there's definitely not return to sport 90s or 100%. So, but it doesn't tell us why some players can return to full competitive sport with full strength and others don't. So how can we answer this question? Probably the anatomical variation of the adductor longus can be responsible for why some players can return to sport and others can't, because the fiber cartilage has different sizes, and maybe that might be the answer. But also, different sports require different requirements, and for instance, in American football, you might not require as much your adductors as you might need in professional soccer. So if you look at the outcomes of this study, they say, well, this all looks pretty good. And so 14 players returned to sport, and after about 6 weeks with conservative management, as opposed to 10 to 60 weeks for the operative group. So in that stage, I'm pretty much happy to go along with this. But then they provide the evidence, and so these are the MRI images in the study, and you can see first immediate post-injury. You can see on the top clearly an avulsed fiber cartilage of the adductor longus, and this is after 6 weeks, where you can see that the fiber cartilage, the black area, is still sitting quite a bit below. But then they provide images, and I would specifically look at the right side, where by some magic trick, the fiber cartilage has creeped up from all the way down back to the symphysis and has reattached. Now, this is not possible. And so, obviously, if your fiber cartilage avulses from the of the adductor longus avulses, it always displaces distally and laterally. So there's no way it can come back to its original anatomical place. So how do we make our decision now on who should get a surgical repair and who's a candidate? I think one thing is clear, that there is a lot of inconsistency in how people are using MRI scans, and what we suggest is to make smaller slides. So 3 mm slides. We find the sagittals very important, and in the patient population that I see in general 4 groups. One with an acute tear and no history of previous groin problems. Some of them had chronic adductor endosopathy and had pubic cleft injections. Some of them had an acute tear but failed conservative rehab, and then some with complication after acute avulsions. So surgical treatment. This is an example of somebody who developed a large osteophyte following an acute avulsion, where resection of the osteophyte was necessary. If you look at the studies, which are very limited, with only a number of cases, as you can see, most of them a good return to sport. But there's also inconsistency in the kind of treatment, because the number of suture anchors are used seems to vary quite a lot between the different authors. Now, if we look at the acute fiber cartilage avulsions, first of all, the partial ones. On the top one, you can see the blue arrow shows that, which is quite typical for an acute avulsion, the avulsion of the fiber cartilage, which is on the lateral aspect of the fiber cartilage. And so this player presented 3 months after his injury with still ongoing pain. The values in pounds of his adductor strength testing are, as you can see on the left side, and following a pubic cleft injection and a strengthening program, you could see that his strength went up quite. In 4 weeks' time, he went from adductor strength 29 to 52, with no pain. So we can manage those injuries conservatively. Now this player had again a partial tear of the adductor longus, but also the secondary cleft signs. So somehow some signs of chronic endosopathy, and in those cases sometimes I'm more inclined to do partial release because we sometimes see that the remaining fibers that are still attached have a lot more load, and that sometimes can be responsible for some pain. So with high-grade avulsions, where only like 10% is left from the attachment, these can be very painful. I don't think there's any sense to wait until they rupture completely. I think surgical management in those cases is important. Now, complete avulsions sometimes can be non-displaced, as you can see on the left. The fiber cartilage is still sitting in place. It's only slightly displaced on the right side, on the axial obliques, and these kind of injuries, in my opinion, can be treated perfectly non-operatively. But sometimes we see players with an acute avulsion who have gone through a rehab program for 6 months and who still have functional problems, so pain and strength loss. And in these cases also we tend to go for reattachment. And so this is the same patient. On the left side you see the typical shark fin appearance. This is on the right side the avulsed fibrocartilage. And think about the previous picture I showed from the study of Schlegel. You see the fibrocartilage is still not back in place. And I don't think it will be back in place in 6 months either. So once it's pulled off, it will remain pulled off. This is another example of an acute avulsion of the fibrocartilage. Now, this is an interesting case where on the top left corner you start with a partial tear. Player was rehabbed and then had another incident where he pulled off a bit more, and then finally where there's a complete avulsion on the top right corner. So you can see the stages how it occurs. So the avulsion of the fibrocartilage always takes place from lateral to central, not the other way around. So it's not a continuation of a secondary cleft sign. It's something different. So for the acute avulsions, you can see the fibrocartilage is quite a big structure. It's the foot plate is very easy to recognize on the avulsion, and it pulls off. And it's about 1.5 by 2.5 centimeters. The way we fix it is with suture anchors. I now tend to use bioabsorbable suture anchors, usually about 4. And this is our rehab program. See, it's a bit of a complicated picture, but you can basically we start with strengthening work pretty soon, after about a week with some close chain work. We go to open chain work around a month, and we're looking at return to sport between 10 and 14 weeks. Obviously, the kicking will not allow the kicking until we, with our adductor testing, we have achieved enough strength. And you can see that the short kicking, we want about 30 on the microfit, 30 pounds on the microfit measurement. Usually for professional athletes, we measure something in between 35 and 55. So you want sufficient strength in order to be able to let players back kicking a ball, basically. So in our study, we've now got over 40 professional soccer players. Return to sport was 10 to 12 weeks, and they all were able to return to the same level. So my take-home message, if you want to, if any, I would say, if you have a player with an acute injury, with pain over the adductor longus enthesis, inability to play sport and to continue sports after you sustained injury, I think this is a true indication for an MRI scan of the adductors.